Good afternoon, everybody. So we've been instructed to be very, very good on time because it's one of the last session of the afternoon and there is a rapporteur session and only 20 minutes break after our session. So I'm Julie Bruno. I'm a researcher scientist in Montreal at the University of Montreal. And I have the pleasure to be with Michael Farrell, who's going to introduce himself.
Hi, my name is Michael Farrell. I'm the director of the National Drug and Alcohol Research Centre in Sydney.
And we're delighted to have you here. I know that it's Friday afternoon, but the session is exciting enough, I think, to be kind of one of the prime sessions of the conference. So without further ado, because I'm supposed to time myself again, I'll present Louisa Degenhardt. So Louisa is Deputy Director of the National Drug and Alcohol Research Centre in Sydney, in Australia. She's leading programs of research focused on illicit drug epidemiology, intervention to reduce harms among people who are using drugs. And I think probably everybody in the room has used one of her multiple maps once in a while. So Louise, thank you very much.
Thanks, Julie. Thanks everyone for persisting at the end of the day and end of the conference. Before I get started, just to acknowledge the very large number of people and organisations who contribute to and provide advice on the work that I'll be summarising here this afternoon. So some of you might be aware that we've just completed the third in a series of global systematic reviews that we've been undertaking since the late 2000s, and we've gradually, with each subsequent review, we've sort of expanded the scope of what those reviews cover. So the reviews that we have recently completed, and I'll be giving some summaries of today, have contained all of the things that we did in the previous reviews. So a systematic review of what we think are the best estimates of the prevalence of injecting, more data on characteristics of people who inject drugs, more data on the exposure to risk and to risk environments that people who inject drugs face, data on a large range of physical and mental health harms, as well as coverage of HIV prevention, treatment and care, HCV treatment, testing and treatment, and other harm reduction interventions, including OAT and NSP. So the methods that we use, and I won't go into it any more than this, but basically we use the same methods in these reviews as we have done in previous ones, where we look at the peer-reviewed literature. We place a large emphasis on the grey literature, and in particular searching a wide range of websites across the globe, coordinating with different international organisations, some of whom are represented here and also on the panel this afternoon, and also consulting with people in country. So this just gives you an idea of what we found in terms of the data availability. This is for the epidemiological review. So in the first one that we did, that was published in 2007, we found evidence of injecting drug use in 148 countries. That is now 190 out of 207 countries and territories. And we also have seen a real increase in the number of countries where the prevalence of injecting drug use is being estimated. The same kind of trend has been observed both for HIV and hepatitis C in terms of countries that have been studying and estimating the prevalence of those bloodborne viruses. So this is the summary of the estimates of injecting prevalence. So you can see that so the lighter blue colours are lower prevalence. The dark grey indicates that there's evidence that injecting is occurring, but we don't have an estimate of prevalence. And then the darker shades of blue indicate high prevalence of injecting. And globally, we estimate that around 14.8 million people inject drugs using 2021 population estimates, which is around 0.3% of people who are aged 15 to 64 years. Luckily, there's no one really sitting up the back, but what we've done here is we've presented the estimates from the previous review with the current review and just showed you what the changes are in the estimated prevalence. And there have been shifts both into higher and to lower estimated prevalence, but that doesn't necessarily mean that we think that that is a real change in the number of people who are injecting drugs, because there's multiple things going on here. Firstly, there are countries where there are estimates for the first time of the prevalence of injecting, so that affects the regional estimates. Secondly, there are new estimates which might be of better quality than previous ones, so that will affect it. In some instances, the injecting prevalence may have shifted, but overall, there's at the global level, we estimate a slight reduction in estimated prevalence compared to the previous review. And I just thought I'd give you a bit of an idea of some of the things that we looked at in terms of the characteristics of people who inject drugs. So the way that we did this is we basically went back to every single eligible survey of people who inject drugs. So there's about 17 or 1,800 studies of people who inject drugs that were eligible in our review. And we extracted all of the information that had been collected by the authors of those reports on demographic characteristics, drug use patterns, sexual behaviour, exposure to risk environments, engagement in treatment and harm reduction interventions, and physical and mental health. So that's the way that we obtained all of this information. So pooling all of that information, firstly at the country level from all of the eligible studies, then making regional and then global estimates. We could make some global estimates about a range of different things. There is huge variation geographically that I don't have time to go into, but I just wanted to give you an idea of some of the things that we've been able to estimate. So globally, just under 1 in 5 people who inject drugs we estimate are women, and that is much higher in some countries than others. So in my country, Australia, it's around 1 in 3. In some Asian countries, it's around 3%. Just under 1 in 4 people who inject drugs are under 25 years of age. And for those of you who were in the session previous to this, just remembering that the focus on young people who inject drugs and the kind of differing needs and ways of engaging people in harm reduction need to be tailored to people who are younger, of which I'm no longer one. I know that now. From the studies that have asked people around how they identify, we estimate that around 9% globally identify as lesbian, gay or bisexual, and just under 1% as transgender. So there's a lot more limited data, but we have basically pooled every single study that we could find to pool those estimates, because we feel that's important, again, as was noted in some of the presentations in the previous session, around thinking about different subpopulations who also have other kinds of needs and experience additional stigma and discrimination. These are some of the risk exposures and some of the physical and health harms that people who inject drugs may face. Again, there's a lot of geographic variation, which we present at country and regional levels. I'm just focusing on the global, otherwise it's just a bit too much. But around 1 in 4 people experienced homelessness or unstable housing in the past year who've injected drugs globally. 6 in 10 had experienced incarceration at some point in their life. Around 3 in 10 had recently shared syringes. Those levels are much higher in some countries than others. So in Latin America, the level of syringe sharing is massively higher than it is in countries, again, such as mine in Australia. And perhaps not surprisingly, that countries in Latin America do not have needle and syringe programs anymore. So that's a real cause for concern. Around 1 in 5 have experienced an overdose in the past year. 1 in 3, a skin or soft tissue infection. Something that receives less attention but will have a massive impact on people's lives, not only in terms of quality of life, but also in how whether people are willing to engage in services for other health conditions. 2 in 3 had experienced recent depression, and that's as assessed using sort of clinically validated scales for depression. And then globally, we have 15% living with HIV and 4 in 10 with active hepatitis C infection. So this is the map showing the variation in HIV prevalence. The purple colours indicate much higher prevalence, and the lighter orange indicate much lower prevalence. So again, you can see that there is substantial variation. And here we've got current hepatitis C prevalence among people who inject, and again you can see variation, but the levels are a lot higher, as you would expect given the higher global estimates. So now moving to the data on coverage. So again, I'm presenting what we found in each of the successive years of review that we've done in terms of the availability of data, but also of the different interventions, but also for some additional interventions that we hadn't reviewed previously. So we haven't seen a lot of change in terms of countries providing opioid agonist treatment between 2017 and 2022, being mindful that Egypt will soon be an additional country. We have got, and we've actually seen a reduction in the number of countries where needles and syringe programs are being delivered, and that's due to the withdrawal of NSPs in Latin American countries. One of the things that I will draw your attention to, because it's important to keep in mind when you look at, when I show you the coverage data, is we actually have a lot more countries where there is data on how much of these services are being provided, and that's important because when you're looking at the 2017 data to the 2022, you're not looking at all of the same countries. We've got more countries where there's now quantification of coverage than we did in the previous review. So this is looking at opioid agonist treatment. The dark blue indicates higher coverage, and what you can see there is, by and large, most countries have low-level coverage of OAT where it is delivered, and then there are many countries, particularly Africa, Latin America, and Eastern Europe, where it's not available. And looking at the quantification of coverage, gee, that countdown timer, Julie, is making me really anxious. I've only got 4 minutes and 20 seconds left. I just use 5 to say that to you. So we've got mostly coverage is low across the regions, and globally it is low. And those really haven't changed at the regional level between the two rounds of review. But just remember what I said before around the changes in countries coming on board with coverage data. So again, this is looking at a map that doesn't look, oh sorry, did I go back? Sorry. This is looking at needles distributed, and this, again, we've got largely low-level coverage with a couple of exceptions in Asia, Western Europe and Australasia. And this is the map on coverage of needle and syringe programs. Again, largely it's sort of low-level coverage that is being observed in countries, with some exceptions, obviously. Now, this figure here that I wanted to show you today is, we wanted to get across that issue that I mentioned before around the differences between the two reviews, the one in 2017, which is the top line and the third line, and the current reviews, which are the second and the fourth. The top two lines are NSP coverage, the bottom two are OAT coverage. And essentially what you can see between the two reviews, the grey bar indicates that where there was no evidence of interventions being delivered. So we've got more countries now where there are interventions being delivered. The blue bars are where we knew that interventions were being delivered, but we didn't know how much of them. And so what you can see between the two reviews is you've got more countries who've started delivering interventions and more countries who are quantifying it. And for those countries, now that they are doing both of those things, mostly they are low coverage countries. So just to bear that in mind in thinking about, global statements around coverage, it is still very low, but that is reflecting the fact that you've got countries coming on, but they are not yet delivering to scale. And globally, we've got 8% of people who inject drugs who are living in countries where there is high coverage OAT, and 3% of people who inject drugs who live in countries where there's high coverage NSP. And this is a figure which I showed the other day, and you might have seen in the previous round of this review that was led by Sarah Lani. Unfortunately, we still only have very few countries who are in the top right-hand quadrant, which is countries who deliver both high coverage NSP and OAT. So just to finish, there are changes in estimates between the two reviews that you just need to be mindful of in terms of, and sometimes they are real. In terms of Latin America, we now know that there are no services being delivered in terms of NSPs in some Latin American countries where they were before. We are seeing changes in coverage estimates that are being affected by the new estimates of the prevalence of injecting, and one good example is India, which has a new estimate of injecting that's a lot higher. And some of the reasons for changes in the estimates could reflect data availability or quality. But by and large, there is low coverage of services for most people who inject drugs globally. Having said that, there has been a modest increase in coverage at the global level, and for some countries there has been obviously clear increases in country. And that's finished.
Thank you very much, Lisa.
Do I go down?
She's so good on time. We may have time for one quick question for clarification if someone wants to come in the mic. Otherwise, we'll keep all the questions for the end of the session where we have half an hour. I have a long question for you, so I'll keep it for in the last half hour. Thank you so much.
Okay, thanks, Louisa. Now we're on to Monica Chupeggie, who's a HIV/AIDS expert focusing on drug use and HIV at the United Nations Office on Drugs and Crime and a national of Romania. She's got over 20 years experience in the HIV prevention and treatment field. And Monica has contributed to the development of many gender-tailored public health initiatives around HIV prevention and related strategies. She's also developed and championed civil society participation in the UN system, and she's facilitated the publication of numerous UNODC technical publications, and she's made a major contribution. So this will be a very nice contrast to our collaboration with Louisa Stoke. Thank you, Monica.
Thank you. Well, I was invited to talk today about successful models of implementation of harm reduction programs, but after Louisa's slide with the huge low coverage percentage and 4 little lonely countries in the upper scale of implementing harm reduction, maybe I should just go home. But let me try. So what I will present today is what we are using in our capacity building programs to support countries to scale up harm reduction interventions among people who inject drugs, among people who use stimulant drugs, and to increase the coverage of women who use drugs by harm reduction services. So you will hear the testimony of people who are actually implementing harm reduction programs. So very quickly about UNODC, just to give you a background, we are the convening agency for HIV prevention, treatment, care, and support among people who use drugs and people in prison. And we do this, our work implementing in synergy the global AIDS strategy and also the UNODC strategy. And of course, in line with the strategic development goals. One document that actually is particularly useful is the outcome document of the UNGAS on drugs, where countries, member states, agreed to focus more on the health aspect of the drug problems in their countries and support people to get access to HIV prevention, treatment and care in the area where we work, and also to increase access for women. I've mentioned before the Global AIDS Strategy sets very ambitious targets that are looking both at access to services, but also on reducing the countries who have punitive laws against key population to less than 10%, to reduce stigma and discrimination and gender-based inequalities and gender-based violence. So harm reduction, Nicholas was talking earlier about the new consolidated guidelines, and here are the interventions that are recommended to increase access to services and decrease HIV incidence and hepatitis incidence among people who use drugs. And you will see here that harm reduction is defined as needle and syringe programs, access to opioid agonist therapy, and naloxone for overdose. So one good example of the country who scale up rapidly access to harm reduction is Kenya, which in a couple of years started in 2014 and increased significantly to thousands the number of people who access opioid agonist therapy. And I want to show you a video of a testimony of somebody who is a client of these services.
My name is Rita Gasonia from Kenya, and I'm a beneficiary of the harm reduction and the opioid agonist therapy program in Nairobi, Kenya. I started my maintenance treatment on methadone in 2015 after having attended a number of abstinence-based rehabilitation programs, and that just wasn't working for me. So when the OAT program began in Kenya, I enrolled myself immediately, and I was there from the year 2015 to 2018. What the OAT program offered me first and foremost was a non-judgmental, non-discriminatory platform for the understanding of my drug use that did not require me to abstain from drug use in order to be part of the program. So I was able to access a lot of harm reduction information about my body, about the effect of different drugs on my body, and I was able to make informed decisions about how to manage and regulate my drug use. The OAT Center also acted as a one-stop shop for many services that I was previously resistant to get in the public health center because of the fear of stigma and discrimination once they found out that I was a person who used drugs. I've been able to access HIV prevention and management services at the OAT Center, TB prevention and management services, hepatitis information, as well as the hepatitis B vaccine. I've been able to access overdose prevention and management support at the OAT Center. I've also been able to access sexual and reproductive health support at the OAT Center, as well as have support groups that have allowed me to organize for the community of people who use drugs. The organization I work for now was in fact at one of the OAT centers in Nairobi. I've also been able to access mental health support. Psychosocial support is normally quite expensive in many parts of the country and unavailable. So being able to access that at the OAT Center has been a big help in my daily life. The OAT Center has also helped me quite a bit in my social reintegration and family reintegration, as the professionals at the clinic have been able to explain my family in a way that they can understand what my drug use looks like and be able to treat in a non-judgmental manner. I think any area that has an opioid dependence concern to think about having opioid agonist therapy treatment as an alternative to abstinence-based treatment, which doesn't often work for everyone. And if there's anyone who's looking to understand their opioid dependence and looking to move from a problematic place to an informed place, then I definitely think that the opioid agonist therapy centers are a good place to start.
What is part of the recipe of success in Kenya is the government full involvement, the funding, and as you heard already, that the community was involved in the development of the project. Women who use drugs, often very hard to reach, very hard to estimate the number of women who are using drugs. Of course, the harm reduction package for women is the same, like for everybody, but it's important to have some key implementing factors that make the services more available and make the women more willing to access the services. So, to have accessible location, to have women-only spaces or venue, to have specific outreach for women who inject, to have collaboration and cross-referral to services, to have secondary needle and syringe exchange, of course, to address stigma, discrimination, gender-based violence, to eliminate the policy and legal barriers, definitely resources, data, and participatory planning and implementation and evaluation. I couldn't find an example from the countries that we are considered high priority countries, because services for women are still quite low. But there is an example from Spain, from Medineres, that we often show in our trainings as a good practice.
I'm Aula Roig. I'm part of Medineres, which is harm reduction service only for women and gender non-conforming people based on Barcelona. Medineres is a new model in Spain where we provide a safe space for women and gender non-conforming people who use drugs. I think that the particularity of Medineres is that we accept the drug use. We have safe space for using drugs, any kind of drugs, and in any way that you can use it or that you want to use it. But we don't put the drug use in the center. It's part of everything that we are doing, but it's not the main part. But we focus especially to give a comfortable space where we can build mutual support, solidarity, where we can do a lot of kind of activities like theater, photography, because we wanted a place where women and gender non-conforming people who use drugs can develop creativity, but most of the women that come to Medineres are surviving multiple situations of vulnerability. Then the main problem that they have is not the drug use, but that they are homeless, that they are struggling with mental health issues, they have been incarcerated, then why they are using drugs most of the time is to cope with all the trauma and violence that they are surviving every day. Especially women who use stimulants are coming to our place looking for a quiet space where they can rest, where they can disconnect a little bit from all this violence and this pressure that the life is putting to them. In that sense, we are trying to provide a full spectrum of harm reduction. They can rest, they have beds, they have a shower, they can washing machine. Most of the people who are working in Medineres are also part of the community. They have life experience. Then and we are building the place all the time together. We have our assembly every week where we try to solve the problems, but also to create new spaces as soon as possible where they are needed, and to adapt all the time the place to the complex reality of the women.
What we can take from what Aura said is that many of the people who are working in the center come from the community, and very important is that women who are coming to the harm reduction service don't have their drug use as the main problem, but many others. So the situation is much more complex than to look at the person only through the lens of drug use. And the last topic that I would like to address, and I'm sure I will go over time, is the harm reduction services among people who use stimulants. We described a package of interventions, and I won't take the time to read everything. The publication is available on our website. Of course, with people who use stimulants, the spectrum is more complex because there isn't only injecting use, there is all form of other use. And the last video that I want to show is from a project in Vietnam who is working with people involved in chemsex.
I'm Executive Director of the Lighthouse Enterprise, a young people population lead organization in Vietnam. And I am also leading the chemsex intervention projects at Lighthouse. In 2019 and 2020, we have done a chemsex study in Vietnam with more than 300 chemsex users participate in the study. So the community basically they face with multiple barriers in accessing the services and also achieving the well-being in their life. I would mention first about the personal level barriers. The lack of knowledge on the drugs and also harm reductions, and the other information about the harms and how they can reduce the risk when they engage in chemsex. They also have the self-stigmatized, like some people they feel that they are not really good like other people because they're using drugs and they engage in chemsex. They also fear of disclosure of their chemsex status when someone from the community knows about their chemsex behavior. And also they also face with the substance dependency and also the mental health problems, not only because of the drug use, but also because of stigma discrimination themselves. In community level, as you know, there are really heavy domestic stigma among the MSM community, LGBTIQ community, towards the MSM or LGBTIQ people who engage in chemsex. And in terms of the services, I would say there are very limited access to the harm reduction services among the community. They don't have enough information, they don't have the accurate information about the services, inappropriate services for them, and there are many needed services that not exist and are not available for chemsex community. And also stigma from the healthcare provider and unfriendly services is also really key barrier. In terms of the structural levels, I could mention about the policies in Vietnam. So substance use is prohibited, and stigma towards the substance user and MSM and LGBTIQ community is very severe in Vietnam. So we implement several activities for the community, but at very essentials and beginnings of any models, we have to engage community. So we organize several focus group discussions and also community advisory board to have a better understanding about the community. What is their needs? What is their issues? And how community can together with us to address those issues that they are facing. So we have the program to educate and raise awareness on different types of drugs. It's harm not only to physical health or HIV/AIDS, but also to the social and psychological and mental health. We also raise awareness on the self-harm reduction, mental health care, preparation for a safer chemsex, PrEP and PrEP and ARVs. We also organize several community events and community meetings, to connect community and integrate them to the broader community, increase their confidence and responsibility to their own health, and reduce the self-stigma among the chemsex user. And we're trying to create the safer spaces for the community where they feel they belong to and where they feel safe to speak up about their issues and also their needs. In terms of the barrier regarding the stigma in healthcare setting, we also have to refer our community to a different healthcare facility to receive services in there. So we organize and several sensitize healthcare providers to make sure that they understand about the community and they know how to provide the proper and friendlier services for the community. And lastly, about the advocacy, it's very, important and extensive part. So we also, together with other NGOs and community-based organizations, to implement several advocacy activities to make sure that the government, law policymaker, and programmer, also with other NGOs and stakeholders, they understand about the cancer community.
So just to conclude, there were many lessons to learn from all these presentations, but what came over and over again is that successful programs are implemented with the full community lead and involvement. Thank you.
Thank you very much, Monica, and we will have time to go over that in the broader discussion. But now I'll introduce Dr. Keith Sabin, who's currently the Senior Advisor in Epidemiology at UNAIDS, and he got his PhD in International Health Epidemiology at Johns Hopkins and Bloomberg School of Health, and he's since been involved with CDC and WHO. So over to you, Keith. And
thank you. So one of the advantages of going really close to the end is everybody's already said everything. So I'll review very quickly what we know and what we don't know, because I've been asked to talk about how are we going to improve data systems for better understanding of the various epidemics and health concerns among people who inject drugs. So one of the things that we have that is advantageous to us are the capacity to advocate around global documents that already exist. The global AIDS strategy is very clear that there is an effort, all countries have signed on to this, to end HIV as a public health threat. It puts communities at the center, and it establishes global targets for services for all populations, including, of course, people who inject drugs. And then, of course, we have the World Health Assembly commitment to eliminate hepatitis C. And then finally, there's the UN statement that calls for the decriminalization of possession of drugs for personal use. But are we having an impact after what all of these statements have done? What we can see here in the shadowy line is that everybody else is seeing a decline in HIV incidence. But what we're not seeing is any progress among key populations. Right? We see, in fact, it's becoming worse among men who have sex with men, with increasing incidence, and rather stable in the other populations. So far, we're failing to have an impact over the past decade. What we know, you've seen this many times already, is that there's a variety of modes of transmission of HIV infection and where infections are acquired in the community. People who inject drugs are very much impacted in different levels in different regions. And that needs to be something that we're aware of. But just because the number is small in sub-Saharan Africa, it doesn't make it negligible. It's a very large continent. There are large numbers of people there that we need to be concerned about and need to improve our data systems and our programs to deliver services. One of the other things that we've already seen Louisa bring up is that injection drug use doesn't always appear in the information that we get. So this is injection drug use in biobehavioral surveys among sex workers, primarily female, but not exclusively, and then gay men and other men who have sex with men. The red line is 0.2%, which was the presumed injection prevalence rate in the underlying population. So we can see that within the surveys of sex workers and men who have sex with men, we have very high rates of injection drug use. And we're not necessarily integrating services for people who inject for the services with these populations. I'm just going to highlight more or less the absence of data, and these are officially reported data to UNAIDS. So that means the countries are recognizing that they have an obligation to report and are collecting those data. So unlike Louisa, we are not proactively doing systematic reviews. We're relying on what the countries tell us, which means if they don't tell us anything, they're willfully blind to what the situation is in the country. So HIV, hepatitis C co-infection, we have some data, not a lot. We also ask for these data among incarcerated populations. Again, very little gets reported to us. And just for those, we've seen repeated calls for data from prison systems. We do collect prevention services from prisons, and we get those basically service provision. So this is Tajikistan. You can see 24 people received OAT services in 2021. So, and we have this for a number of countries, not a lot, but we do have a number of them. Now I want to come back to the main issue, which is willful blindness of countries towards these populations. This is an analysis we did internally for the number of people who inject drugs. These are the size estimates. On the bottom are the officially reported numbers to UNAIDS. So just under 6 million, right? 2.5 million are believed to exist in countries that reported to us, but reported with inadequate methods, or they might have been good data, but from a single city in the country. And then finally, this is our extrapolation to the rest of the world. So we come very close to the 14 million that Louisa was estimating, but these are the only people who are considered to exist by the countries in which they reside. That's a huge problem if the countries don't recognize that there are people who inject drugs within their borders who are in need of services. Some of the methods that we used were to take data from the regions and extrapolate out, and this is just some work that colleagues at Imperial College have done, where they've collected roughly 200 size estimates from sub-Saharan Africa across roughly a little less than half the number of the countries that had data. And they did an extrapolation, and this is their prevalence of injection drug use on the continent. We also looked at HIV prevalence in ART using similar methods. So the preprint is out if you want to get it. Further, not only do we not have data on the numbers of people who inject in many countries, when we do get data from service coverage, we're not seeing coverage that is anywhere near adequate. So this is probably the most impacted region by UNAIDS regional titles, the Eastern European and Central Asian region. And the outer dotted line are the targets. Those are the global targets for each of these services. And you can see that we're nowhere close. PrEP is almost close because they don't really have much of a target in the region yet. So that remains to be changed. So if we're not covering services in the most impacted region in the world, what are we doing? And this really is one of the better service coverage rates that we see. Services are low not just because they're not on offer, and again, look back to Louisa's data to see where it's offered, but the levels of stigma and experienced violence that people who inject report, and these are the only countries that reported to us these data over the past 5 years. So that's a problem in and of itself. But where it is reported, it's nowhere near the 10% target that we have. And the fact this keeps people from seeking services. We hear this repeatedly from community members everywhere. So this is something else that we need to address. How are we going to address it under the current economic crisis? What we've seen even before the current crisis is flat funding. We are not seeing increased funds, and this is specifically for HIV, where there is fairly good political will to do something about the HIV epidemic in countries around the world. And yet, funding remains flat, and that's both domestic funding and international funding. And this is what UNAIDS estimates is the resources needed, or the resources needed just to achieve the targets that we've set for 2025. So we're a long way off from where we need to be on the financial level as well. Some countries are doing reasonably well at allocating funds. These are the resources that have been allocated by countries specifically for prevention services for people who inject. There are for other countries available on our website, but I just wanted to give you an idea. Ukraine has always been very strong. Bangladesh is a bit of an outlier, given that their injection drug use issue is not as great as some of the other countries in the region. So all of this brings us to the question of how are we going to improve systems? One, we need to improve services. There's no point in collecting the data if we don't have services from which to collect the data or about which to collect the data. From my perspective, and really I think I echo my UNAIDS colleagues at a minimum, if not my UN colleagues as well, communities can and must lead on data collection. We need to create lighter and simpler survey systems, right? We cannot do probability-based surveys every 2 years in enough places to have meaningful data. Recently, we piloted a fairly simple project with the Georgia Harm Reduction Network. We interviewed and tested for HIV and hepatitis C 2,000 people who inject across 7 cities in the country. We did it in 6 weeks for a total of $75,000 committed. This combined a type of sentinel surveillance with snowball outreach, so we weren't only getting people who were using services. And the testing was offered through the existing testing system. We weren't offering anything that wasn't already available. We also did the same process in Uganda, in a semi-rural eastern district, where they did not have any harm reduction services whatsoever. So there was no community to go to. So we worked with the government in that region, and these are just some of the results. We recruited a little over 400 people, and a quarter of them had never used any HIV services in the region. And so you could see just here what we found. So 3% prevalence, they didn't think there was much injection in the region, much less that there was this level of HIV prevalence in the region. So how are we going to close these gaps? Well, I think we need to hold national AIDS programs and ministries of health accountable. The Sustainable Development Goal explicitly states that there are targets to achieve service coverage for all subpopulations, including people who inject drugs. We have to hold our donors accountable for supporting measurement activities. And let me add a qualifier to that. Not only do they need to support the measurement, they need to support the reporting of the results of that measurement. The number of surveys that are conducted without a report it's unethical and it's really horrible. The fact that we only get a PowerPoint slide with a table, and that's the result of $500,000. That's not acceptable. Women, where are they? I just saw data from China. People who inject drugs in their sentinel surveillance system, the women had double the HIV prevalence rate as the men. I didn't have denominators, I just saw this afternoon, but it just goes to highlight the issue, and we're not collecting those data. We ask for it, we get some data, it's regrettable. I think we also need to expand expertise. We need to start building capacity, and we need to recognize where expertise exists, and that is in the communities, not coming from outside the communities as some exogenous factor. And then we need multi-community collaborations. As I showed earlier, men who have sex with men and sex workers have injection drug use in their communities. We need to work more closely with them so that there's a holistic approach to both HIV, hepatitis C, and all of the issues that confront these communities. I think we need to set up a global reporting system for communities. We're thinking about creating a platform where communities can publish their data so that we know how many people are getting tested from site to site, and that it comes to a global platform. It doesn't have to pass through a government system. Something simple that can be uploaded quickly and that provides feedback in the form of some visualization fairly quickly so that it can be used locally to show a trend in HCV seropositivity in the number of tests that are performed. And then finally, how do we address the funding issue? I think, I don't think these are any new ideas here, but I think we need to engage with the Clinton Foundation to see if they can bring down prices of DAAs in the way they did for ARVs, if they're not already working on that. I'm not aware. I think we need to engage the Global Fund more because although they're very supportive of harm reduction activities, at a country level, we tend to fall down if the local CCM, the local coordinating committee, is not actively engaged on harm reduction issues. We have to go back to PEPFAR and keep hammering it there. I've not seen them as engaged as they have been in the past, and then perhaps approach the Gates Foundation. You know, sometimes you might have to hold your nose, but they also have a lot of money and they do good work as well. And with that, I'll close by just saying what we know, you can know as well. We have different websites attached to this link, and you're welcome to access and download our data sources whenever you'd like. Thank you.
Thanks very much. Any questions or points of clarification for Keith? Given that he's stuck to time, we're going to... No. Well, I'll just say thank you very much. I'm afraid I have to leave a bit early because I have a plane to catch, and I'll be handing over to the capable hands of Julie and the speakers.
Thank you so much, Michael. So I'm abandoned, but I'm not abandoned with very nice people, and I'm very happy and pleased to introduce Judy Chang. Judy Chang is the Executive Director of the International Network of People who Use Drugs. She's been an active person within INSU and have really helped us grow as an organization who give the voices to people. She serves in several steering committees, advisory board, and working groups all around the world for global health, and she holds a master's in international development. Judy, please, thank you.
Thank you. Good afternoon, everyone. So for the next few minutes, I'm seeking to respond to how can we use advocacy and community-led monitoring to improve coverage and quality of services to reduce drug-related harms. So just to preface this by saying I'll be speaking from my perspective as the ED of Input, where our team work actively in the multilateral UN space to really drive the issues that we see as important forward. So it's still a limited view. Of course, there are many ways to do advocacy and community-led monitoring, but I just thought I'd share what's on our radar and what we've been working on. So a lot of the advocacy that Input and its members have been a part of, we do jointly and in collaboration with key populations, so sex workers, gay and bisexual men, transgender people, as well as people living with HIV, because there's a lot of, as Keith also shared, there's a lot of commonality of issues and priorities. And a lot of our work is about getting policymakers and programs to really go beyond, disease responses, but recognize complexity and also plan to take action against inequities and injustice that are created by people in power and vested interests. And these are what negatively impact upon health. For example, if we look at the war on drugs. So in 2021, there were several political opportunities at the global level that really opened up for us in terms of advocacy. So there was a global AIDS strategy, which was finalized in early 2023. And in July, there was a political declaration on HIV/AIDS. And that was passed by the majority of member states. So there were targets that were passed on opiate agonist treatment. So it was 50% coverage target. And there's also a long-standing 90% target on coverage of needle syringe programs. But in this year, Input, along with allies, pushed for the 10-10-10, what are known as the 10-10-10 targets on societal enablers. That also include targets for decriminalization of drug use and possession and the removal of punitive laws. And there are also, importantly, the 80-60-30 targets on community-led responses. And these were targets that member states committed to. So these targets have to do with funding. The 80 was that 80% of HIV prevention programs are run by community. 60% of funding for advocacy and societal enablers should be led by community. And 30% is that 30% of HIV treatment programs should be run by community. So I think overall it was, successful advocacy or successful negotiation of the political declaration. And I would just emphasize it was a surprise, I think, to many of us. We're seeing globally, a growing anti-rights lobby, shrinking civic space, and of course also shrinking funding. Like, we really thought there's no way harm reduction interventions are going to be mentioned, and we thought there'd be, less focus on key populations, when in fact, it ended up being the other way around. So basically, this is the first time that there are global targets on decriminalization of drug use and possession, and also across key populations, stigma and discrimination, gender equality, working towards gender equality and community-led responses. So as community, we see we can leverage these targets to really move the needle on access and quality of services, as we still see. But of course also, focusing on the societal and structural barriers that had never really gotten as much attention, but of course are primary barriers. So these newly passed 2025 targets, and specifically the 10-10-10 and 80-60-30, are incredibly ambitious, but we need to also think of them as course correctors, right? As we saw with HIV and COVID, they really demonstrated that epidemics, pandemics, really thrive along the fault lines of inequity. And it is, political will and political choice that really determines success or failure. We can have the latest biomedical advances, latest treatment, but if they're not going to get into the right hands because there aren't the right mix of policies, laws, and people, then we're not going to progress. So I don't know if people heard of the UNAIDS fast-track targets previously that were very much focused on treatment. We see the 2025 targets as huge progress because they do better serve the advocacy targets that community, have been working towards. And we see them as a tool to be able to demand our rights and hold governments accountable. During the political declaration, it was all countries but 4 that actually passed the targets. But we also know, they need to be more than just numbers and words on a piece of paper. So what we really, do talk about the importance of is that there needs to be dissemination and knowledge of these targets, because a lot of, multilateral decision-making, global decision-making happens behind closed doors. 2, there needs to be early and robust tracking of progress towards these targets at the national level. UNAIDS do have a framework on reporting on the 10-10-10, and as well as working on tracking resourcing to community-led networks. And as Keith also said before, communities have a key role in this tracking and the monitoring. With global commitments, we know that they also, can't just disappear into the void. They must be, and work needs to be done to align them with regional and national action and mechanisms. So to change rhetoric into action, communities will need to be demanding alignment and find ways to leverage the targets. So we know that, social change, political change has never been offered on a plate. As community, it'll be important to keep track of national decision-making processes and seek entry and advocate for the 2025 targets in the development of national strategic plans on HIV/AIDS, and also the CCMs, which are country coordinated mechanisms in Global Fund funded countries. We also urge members to apply for technical assistance funding under the UNAIDS mechanism. There's a Global Fund short-term technical assistance as well, because we understand the key importance of needing to make sure, this advocacy, this community-led advocacy, is funded, and the push for human rights. In terms of community-led research and monitoring on progress towards the 10-10-10, 80-60-30, we're looking at how to elevate and really push shadow reporting on the Global AIDS Monitoring Framework, as well as through the UBRAF. But I think also for community-led monitoring, there's also, human rights mechanisms, and that applies to, all countries that are part of the Human Rights Council, and they can also be used to drive government accountability. And, as we've seen the last few years, where we've been supporting communities to take the lead in developing shadow reports, that, it takes funding, it takes support, but it's another additional mechanism that we can use. At the program level, of course, we can use CLM to monitor service access and quality. But, as we've seen and from experiences, we also know that the program managers and policymakers need to, commit to taking the evidence seriously and act on this data as well, whilst also ensuring, safety and security of criminalized populations. So some of the work that we're doing on disseminating knowledge of the targets. So these are some photos from national workshops on the 2025 targets. It's part of our Rights, Everybody's Rights training program that Input has been running, funded by UNAIDS and supported by UNODC. And workshops have been run in Indonesia, South Africa, and Nigeria. Of course, other forms of advocacy, critical pieces, and I know it's been talked about a lot throughout the conference, about also direct action protests also. Of course, we can use different methods in different contexts at different times. Okay, so back to funding. The graph on the right just shows shows the severe disparity between the amount of spending needed on advocacy and human rights work and the amount of money, well, the gap of spending between what is needed for key populations and what exists. So what else needs to happen in terms of funding and also alignment of the targets? We also urge that all global health governance and funding bodies concerned about the HIV response, such as the Global Fund and PEPFAR, must also align their strategies and funding allocations towards the 2025. And this is something that we'll be, looking at and pushing at over the next year as the Global Fund is going through their next round. It's really important to remember that across all member states, we can't let them ignore that the targets have been committed to at the global level and really, push the importance of integrating these targets into national planning. Of course, national policies and programs must also align with normative guidance, such as the key population implementation tools, which were developed in collaboration with community-led networks and leaders. For people who use drugs, inject drugs, there is the I Do It, and that was developed in partnership with UNODC, Input, WHO, UNAIDS, UNDP, USAID. So when we're looking at societal and structural barriers and the push for decrim, you know, we see the focus on these new 10, 10, 10, 80, 60, 30 targets as really constituting, you know, the last mile of the HIV response. You know, in global decision making, which can be like a juggernaut, you know, it is surprising that it's taken 40 years to actually, you know, have these targets. I mean, they are ambitious. They are 2025 targets, which means there are like 3.5 years to act. But yes, we all know it's a difficult moment. There are concurrent crises, but you know, as we saw with COVID, and as we're seeing also with Ukraine, and as we saw with HIV, it is really communities that stepped up where health and social systems failed. You know, and these systems failed because they weren't designed to respond to emerging threats. So I think what the last few years have shown us is that it's very important to be ready to adapt and innovate, which is what communities have always been best at. Thanks. I think I went over time.
Thank you very much. Maybe I'll ask the speakers to come and join me on this on the stage so that we'll have a discussion period. So we have about 20 minutes discussion. So anybody wants to launch the first question? Jason.
I'll just wait for them to sit down.
Just
Get settled.
Okay, Jason.
Jason Grebley, Kirby Institute. So first of all, you guys, like, perfect. Thank you so much. Great presentations. You know, I know that we were involved doing stuff with Louisa on the global reviews, so I've seen lots of the data many, many times, but you see it presented a couple times, and you start to get a bit angry about the fact that we haven't seen any movement in the harm reduction sort of coverage globally. And Judy, you touched on some of the things that we can be thinking about doing. Clearly what we're doing right now is not working. We're not getting lots and lots of countries all of a sudden taking things on. And I know that there's a range of reasons for that and various access barriers and so forth. But I'm just sort of wondering if you guys have any insights. Now, you each touched on it a little bit in your presentations about what are some concrete things that in the next couple years we really need to focus on in terms of bringing us together. And I think maybe think of it in two levels. One is what do you think are big picture things that we need to consider doing? You know, we meet, and I guess I also think, what do you think, you know, INSU as a forum maybe for discussing this? Next year, you know, we've set this, how do we continue the conversation? Do we need to create spaces to bring people together? Do we need people from Global Fund and PEPFAR? Are those discussions already happening? You know, Keith and Monica, you know that. And then also, the things that you think that the people in this room need to be doing as researchers, clinicians, community, to contribute to that effort. I don't know where to go. We keep talking about it. I'm just really curious if you guys have any insights, because a lot of you have been working for this in decades. So I'm reasonably new compared to your history. But what has worked? Do we need to find countries that are kind of on the line and just need that extra catalyst to go? So should we be identifying those countries and then really focusing on those? Are you guys already doing that? Sorry, I know it's a long question, which is not uncharacteristic, but yeah.
So thank you so much, Jason. It's like, I think there is 4 questions if I can summarize what you're saying. But maybe the first one I would pick up is, before going to INSU and the funding, is what would be your wish list for what could happen next as far as, because all these targets and all these things that we want to achieve, how do we measure them, and what would be, because I really like the idea that you all, I think, touch upon about the using the community, the people, to have very simple measures and then to try to to have the pulse of the community. But if Luisa had to do another review in 4 or 5 years, what would be the indicators or the things that we would like to see from those gray countries and everything? So maybe anyone jump in? I guess Keith, I'll push the button there.
There's so much. I think I've seen a little bit of backtracking from donors, maybe not on purpose. Certainly at UNAIDS, we've lost some of the programmatic expertise we had in harm reduction, and we've replaced it with somebody who fills gaps but doesn't bring expertise. And so I mean, we've lost 100 posts in the past year at UNAIDS globally. So we're all doing double, triple duty, and that makes it really difficult for us to engage with our country offices where most of the work to push and to promote civil society reactions comes from. So we do have these conversations with the Global Fund. We have a working committee that we meet. We used to meet over lunch. Now we meet on Zoom. But even though we sit a few 100 meters away, and we're all sitting there lamenting, what do we do? And I think I like the idea of, I mean, there must be low-hanging fruit. There must be countries that are at that tipping point. But there's so many pressures that are coming down from so many directions to push the agenda in not competing, but it's a zero-sum game for people's time right now. And that's the biggest difficulty we face. And I think people are looking for the easiest way out, so PrEP. I mean, that's what you'll hear on my floor at the office. We just got to keep pushing PrEP. And in the Uganda data, we had a surprising number of PrEP users among the people who inject. We thought that was wrong because we didn't think they were promoting it that heavily, but they had a high target set by PEPFAR. So there was a lot of PrEP use among people who inject, which is great, but it was a surprise to us. And I'd hate to say that's the answer because I don't think it's the answer, but it is where the donors are going. And I think we maybe need to think, how do we adapt to that reality? Because even though needle and syringe programs are cheaper and probably more effective in the long term, there's not a lot of stomach for it among certain donors. And that's something that we have been combating for 20 years and are still combating. And so I don't have a simple answer for this. I wish I did. If I had, I would have said it.
Judy, Monica?
Well, you see, I mean, as Keith said, it's complex because when it comes to, see, you don't need for any other intervention or health intervention at the country level, you won't need a law to allow it or a parliament decision to start it. So first is the political context. And here the 10 target comes, you know, to reduce the number of countries who have punitive laws against all the key population, but in our case, people who use drugs. Then there are the stakeholders, because in this room, we have people that agree that this is a good thing to do. And we stay in our bubble because it's easier to speak with people that agree. But you need, in order to increase access, in order to make a more welcoming environment for harm reduction interventions, actually you have to convince those who are not here or are not in the harm reduction. Jason, I'm not criticizing this conference, but are not in the harm reduction conference, are not in the regional harm reduction meetings. So maybe they won't come to the harm reduction or medical or hepatitis or AIDS conferences. So maybe we need to reach out to the meetings that are organized for law enforcement, for prisons, and give them the right examples, and the arguments that they relate with. Because a police officer on the street has a certain indicators that he had to meet in order to get his salary at the end of the month. None of these indicators are to decrease the prevalence of HIV or hepatitis. So this needs to come to that group of people. And we're trying at UNODC because the mandate of this organization is so vast. But I think more of us have to go and speak with that group. And then is the funding, as Keith rightly said, and the funding for harm reduction is very limited. There was a publication saying that 2 cents are allocated for harm reduction interventions, and I don't think it increased. And even if the funding for HIV interventions increased at the Global Fund now, 14.2 billion, this is wonderful. But we are yet to see an increase in funding for harm reduction, and this is tricky because the applications are coming from the countries. And so the country has to recognize what Keith was saying earlier, that this population exists, and there are needs that has to be addressed in this population group. So as long as the country applications are blind to people who use drugs and people who inject drugs, you won't see an increase in the funding coming from the Global Fund because this funding is not requested. And then, when I can talk about this forever, but then even if the funding exists, because this is my life, even if the funding exists, it stays there. There are examples, and I won't name names, but funding for OAT stayed in some countries in South Asia for years and were not spent because there wasn't the will at the country to implement the funding. And right now they said yes, and we will support them to implement this. So, and then again, the fact that community is not involved or very little involved, it decreases the quality of the services and increases the acceptability of these services among this group of people.
It's kind of a vicious circle in
So
the way what you're saying.
just opened the Pandora.
Did you want to?
Sure, yes, even though I spoke about these shiny funding targets for community-led responses, of course, yes, super worried and, veer between optimism on the NFM Forbes I see as an opportunity and, yes, a lot of pessimism for all the reasons that Monica outlined as well. In terms of, looking at things that could be done, I guess it is producing information, research output that would be able to influence, some of the issues that we do see with Global Fund funding. I don't think there's enough understanding of harm reduction. For example, we've seen so many stockouts in countries of OAT, just over the last year, and I think the country team staff just don't understand that it's not the same as, ARV, that it's a real risk to people's, mortality, and there's been overdoses and people being, incarcerated. So, yeah, there doesn't seem to be that understanding. I guess another kind of key opportunity linked to funding, well, not opportunity, but an issue is the pandemic preparedness response, right? So we see that even though during COVID, people who use drugs and people who inject drugs were disproportionately impacted, with, all the focus on pandemic preparedness response, it's really squeezing, I think, people who use drugs, but also key populations out, and it's another reason, not to allocate funding and to start diverting some of that funding. So I think also looking at ways to raise understanding and visibility of the impact on people who use drugs through research, through policy briefs.
And maybe a follow-up of Jason's question, and there is another question in the room from Anne-Sophie, is how would you see a conference like INSU being a forum to think of these things and maybe have the time to do it. And Anne-Sophie was suggesting maybe spots at INSHU for specific country discussion around these things for specific countries with people fly. And I know that there's the policy day. You see the policy day and the INSU conference having a role. It's, I don't know if you want to answer your question, Jason. Or,
No, I want to hear an answer, but I think, and look, I don't need to, there's not that many extra people, and people know, I think, next year the conference will be in Geneva. And, so I think there is somewhat of an opportunity in thinking through ways to bring people together. And I would love to hear, whether it's, I'd love to hear you guys' thoughts now, but from people as well about ideas of innovative things that we could do, because I think there's opportunity to provide space for discussions to happen, but in Geneva with all of these international organizations and thinking through, that's why I wanted to know what you think we could do and who do we need to bring together. I don't think that'll be the one thing, but if it could be just like part of the puzzle to help as an additional thing, maybe, but I'm not going to say that one meeting's going to do something different than decades of trying to do something, but I think, we saw that with INSU Africa, that bringing people together from these countries actually did mobilize things to happen in some of the countries after the conference, and so thinking through how can we do that. But yeah, I'm curious to hear you guys' thoughts of who do we need to get together and what might be helpful.
Since you'll be in Geneva, I can pretty much promise I'll come back. No, I think it would be interesting if we could find a governmental mission to host an evening for the other missions to the UN. That means they'll invite representatives from all the missions to come maybe show one of the documentary films, something like that. I've seen some pretty impactful films at the harm reduction conferences when they have their movie nights. But this is something that we do at UNAIDS around different topics routinely. We often get a good turnout. You just need a government to support it. Luxembourg is usually pretty good about that, but ironically. But there are countries I'm sure that we could convince that this would be something that they'd want to do, and we can put together a few countries, perhaps, to support an evening where we bring in UN mission staff and we go directly to the countries and talk to people there. That would be one option.
I think he thought about it before
Yeah.
saying it.
Yeah, I'm not naive.
You can also invite, have a session and invite from a certain region, because it's expensive to invite from all over the world. You can invite health professionals who are working in prisons, for instance, and discuss the hepatitis C and B prevention and treatment in prisons, and have them at the table and see what they are saying and how do they see advancing this in their countries.
And being in the air of Geneva, maybe it's going to do something. You never know. I'll use my prerogative, I guess, of chair to ask a question to all of you, because I like the idea of the platform to collect, to report data, but I was wondering if one of the things that the community can have on hand is also simple platform to collect the data, and that in a form that is possible to extend to different countries, and then the reported data could be done centrally, obviously with all the ethical issues possible. Is it something that has been thought of, or because I'm thinking of the 10-10-10 of Judy and
Thought of, yes. Again, it's a resource question.
yes.
We do think that there would be the possibility of some kind of website where you could enter very clear numbers. Others have said, well, just accept Excel spreadsheets, which still requires some, either way you need an internet connection and data service, or you need access to some sort of spreadsheet program. But these are the things we've looked at. we've thought about how do we do this with a Shiny app so that you're just putting up the data, and when you hit run, it will generate some feedback right away that can then be downloaded, and you've got your infographic ready to go. So we've had some experience with this, not necessarily with community groups, but this is the thinking, and we've asked for money for this from my friends at the Gates Foundation. We'll see what we get.
Well, one other thing as well, I think there's so many issues, right? How can you possibly cover everything? And I think the important thing would be, like, if people who use drugs were going to engage, or community, it would have to be an issue that, you know, we really care about, or that particular locality. Yeah.
That's why I was thinking of the 10-10-10 and saying, because obviously knowing the 10-10-10 is something, because knowing 90-90-90 was useful, but then after that, if we're researchers, we want to measure things. It's like, yeah. Any other questions? Oh, sorry, I haven't seen you.
Hi, it's Anne Livingston. I'm from Vancouver, the drug user
Can you
organization.
speak closer, because we
Sorry.
hear nothing here?
I'm going to set off this fire alarm over here. My question, it's Anne Livingston from Vancouver. It's an observation, but also a question. I get the impression that when we're talking about the World Health Organization or anything with the United Nations, there's a kind of how dare you boss us around as a middle or low income country, or whatever, I can't remember the terminology exactly, when the US, the most powerful country in the world, treats their drug users probably, I mean, it's just shocking. And so I always think there's some kind of a cynicism with it. They just can flip off and say, you know, what do you mean? You know, they're all in jail in the US, they don't even have needles in a lot of places. Fentanyl strips are illegal, Narcan is, you know what I mean? Just the shocking horror of the United States. So anyway, I was just wondering if there's any, that's the impression I get, where if I had someone preaching at me about how I should do better for this marginalized population, I think I remain unconvinced, in the sense that if the US can get away with doing what they're doing, you know, it's kind of like telling you to fuck off or something. You know what I mean? Just how could we take this seriously? And then the question is there anyone else who's thinking of this and saying, I mean, they don't get aid, but you feel like sending aid. I feel like packaging up, I've done it, packaged up needles, because I can get them free off the government in British Columbia, and mailing them to the States, and also Narcan kits and stuff. So, I mean, is there anyone else concerned the way I am about this, that it's really holding back a lot of the sort of geopolitical, I guess that's the right term, the politics that go on? That's my question.
All right. Hi, Anne. We met back in 2000, I think. You gave me a tour of the safe injection facility in Vancouver. Thank you. As an American working at the UN, who was paid for by the US government to work at the UN, I have a very mixed relationship with that. We do call out the US among many other countries, usually for lack of reporting, not reporting how bad things are. Right? Most of the data we get from the US has already been published by CDC or some other entity with responsibility, and you know, it's often not depicting anything good, and it's usually 3 years old by the time we see it. We get better data from South Africa, frankly. But the US and Russia are kind of in the same ballpark with this. And you know, we tend not to call countries out explicitly. We simply show their absence of commitment, even though during the negotiations for the political declaration, they were very, very supportive of inclusion of harm reduction and all services for key populations having targets. They're schizophrenic. And that's just something we have to deal with. They give us a lot of money to do what we do around harm reduction, but they don't spend that money at home. They'll spend it in PEPFAR all over the world, but they won't spend it, you know, in Pennsylvania.
Sorry.
On this note, I guess, I would like to thank the presenters. I will have this session to a close. This is the last session before the reporter session, so it's in 20 minutes. The break is 20 minutes. The exhibitor room will be closed by 4:30. If you have anything in there, you won't be able to access it after. And I also have in the housekeeping that you probably know that the sessions and the posters will be available for you for 3 months on the site of the conference. So that's, if you've missed anything, like me, you've missed a lot of things, then go. So thank you very much. Thank you. Thank you. That was a great. There's so much.